everyone. If everyone could grab a seat, we're going to start the program shortly. Great. Well, thank you, everyone, for joining us for Enabling Global Health Security Through Health System Strengthening, Perspectives from Women Leaders. I'm Tina Flores. I'm Vice President of External Engagement at Rabin Martin, a global health strategy firm based in New York. It's my pleasure to welcome you today on behalf of Rabin Martin and our partners, Management Sciences for Health, No More Epidemics, the Global Health Council, and the U.S. Pharmacopeia Convention. We would like to especially thank Allison Corbaccio from MSH and Katie Zabronsky from Rabin Martin, who organized this event on our behalf. The ongoing health threats have pushed global health security to become a major development priority, exposing weaknesses in health infrastructure around the world. Indeed, we've learned that crises, be they from disease, natural disaster, or conflict, comprise a delivery of prevention and treatment from other critical issues, including NCDs, maternal and child health, and HIV/AIDS. International health regulations and the global health security agenda mobilize country-led multi-sectoral action to facilitate building more resilient health systems that are better able to prevent, detect, and respond to disease threats. We are at the precipice of accelerating progress toward achieving the goals outlined in the IHR and the 11 GHSA action packages. But it will require country leadership, political commitment, and multi-sectoral action to get where we need to be. This panel was inspired by a conversation between two of today's panelists, Dr. Rebecca Martin and DIAH SAMINARSIH, who will be arriving shortly. They began this at an event co-hosted by the Private Sector Roundtable and PATH during the UN General Assembly last September. Essentially, they posed the question, what are the factors that enable greater health security? As to the other half of the event's title, here's DIAH. Perfect timing. Perspectives from Women Leaders. The reality is we pulled together a great panel of experts in health security, and they were all women. So case in point is today's moderator, who happens to be a very good friend of mine, LOYCE, who is President and Executive Director of the Global Health Council. Many of you in this room know LOYCE through her various leadership positions in global policy and strategic partnerships at the Livestrong Foundation and ACS. Without further ado, I'm going to turn this over to LOYCE.
Thank you, Tina, very much, and welcome, everyone. No applause, no applause. It's a pleasure to be here with you today and be moderating this esteemed panel of wonderful women and sisters in the fight in global health. We decided to switch things up a little bit today. As you could tell, we will go ahead and break up the panel when the Honorable Minister of Health from Uganda arrives, but until then, we'll go ahead and get started, recognizing that people have tight schedules during World Health Assembly. So hopefully everyone is okay with that change. I did want to start by, again, saying that I'm LOYCE Pace of the Global Health Council, and thank you again for having me. I will also go through and briefly introduce each of the panelists, but want to call your attention to the printed full biographies of each of the panelists, so hopefully you all will beg our forgiveness not to read those and allow you to look over those yourselves. But as Tina said, we are very happy to have brought together this group who represents a broad spectrum of stakeholders focused on global health security and interest interested in this issue, representing government, industry, and civil society. And so we're very happy about the diversity of perspectives that they offer today. In terms of other types of diversity, we were intentional about bringing together a group of women. And as Tina mentioned, they are the best in the biz. So in addition to highlighting their work as individuals, we want to acknowledge the impact that they're having in this space. And I think you'll be excited to hear more about the initiatives they lead. And so finally, for me to go ahead and get started with those intros, I will start with Dr. Kate Bond. She is the VP of International Regulatory Affairs at U.S. Pharmacopeia Convention. Welcome, Kate. Thank you. We also have TERRI BRESENHAM, Vice President and CEO of Sustainable Healthcare Solutions at GE Healthcare. Welcome, TERRI. Dr. Beth Cameron is the Senior Director of Global Biological Policy and Programs at the Nuclear Threat Initiative. Hi, Beth. Jennifer Esposito is General Manager of Global Health and Life Sciences at Intel Corporation. Dr. Rebecca Martin is Director of Center for Global Health at U.S. Centers for Disease Control and Prevention. And finally, we have Ms. Dina SAMINARSIH, Special Staff to the Minister of Health of the Republic of Indonesia. Hi, Dina. So I want to start us off with a question that each of the panelists will respond to, just take a couple of minutes to respond to. And it's really drawn from our focus on this not just as a global health security issue, but acknowledging the fact that global health security has implications for health systems. And so really thinking about how we can be more proactive and less reactive in this space and focus on upstream issues. I'd like each of the panelists to respond to the following question, which is, what needs to work in a healthcare system for us to be successful in combating the issues around global health security and for us to really enable and foster greater global health security? I also would like, if you're able to, please answer this question not just in terms of health systems, but also systems that relate to non-health factors as well, because I think we want to recognize the whole ecosystem. So I will go alphabetically, if that's okay, and start with Kate.
Thanks very much, Loyce, and thank you so much to all the organizers for this great event. It's really, truly an honor to be here with these extraordinary women leaders in global health security. I wanted to just start with some reflections. I actually spent a lot of my early years of my career really learning a lot from women on the front lines. I spent a lot of time in the Mekong region of Southeast Asia, and back in the early 90s, a lot of young women were very vulnerable to HIV infection, in part because they had no opportunities for employment and were trafficked into sex work. And I learned from them, even despite being HIV positive and having no access at the time to treatment, just the extent to which they themselves supported each other and engaged in the prevention efforts to ensure that their younger sisters who followed would remain free from HIV. About 10 years later, we found ourselves with a new pandemic threat. There was SARS and H5N1. And during that time, a lot of effort to, again, deal with many of the cross-border issues related to these threats. Really amazing women on the front lines of the district health services who were devising very innovative ways of both cross-sectoral collaboration and cross-border collaboration. They were devising teams that comprised of health workers and livestock workers and others, border control, et cetera, to develop joint outbreak and response across the rivers. And this was rather innovative and something I think that the whole global health security movement is now picking up on. It wasn't really until I joined the US FDA under another incredible women leader, Peggy Hamburg, that I really appreciated the extent to which medicine's quality and safety and efficacy was critical to global health security efforts. And also, obviously, the role that national regulatory authorities play in securing safety, quality, efficacy. As we know, when we have poor quality medicines, we end up with therapeutic failures, treatment failures, toxicity, and even resistance. And essentially, this leads to a complete breakdown in trust in the health system as a whole. So this is one of the areas of global health and health systems that tends to be less visible, but yet very, very important. So now at USP, it's an organization that for 200 years has been working to safeguard medicine's quality in the United States and increasingly committed to global health efforts, is working really to support national regulatory authorities, working with WHO toward supporting manufacturers to be able to provide quality assured medicines, essential medicines. This type of work, I think, is really getting at the next phase of global health security. I had the pleasure, actually, of going back to Southeast Asia a couple of months ago and back to Myanmar, and I visited the first ever internationally accredited quality controls laboratory. My colleagues in USP who work through the Promoting Quality of Medicines program supported by USAID had done a lot of work to help with the technical requirements for the lab, but also training the technicians and the staff who assure the quality of medicines in the lab. And I was really amazed to see, first of all, it was led by this very dynamic woman, Dr. Kinshit, but about 90% of the staff in the lab were young women scientists and technicians, and many of them had come from border areas themselves. So I thought that this was just a tremendous sort of sense of hopefulness and optimism that they will be deployed to those same areas to safeguard medicine's quality, but they too now will have a different kind of path in their own lives in science and in public health, and contribute continually to women's leadership in global health security. So I think for me what this really means is, working across borders, working collaboratively, but also continuing to gain inspiration from the courage and the resilience and the creativity and the collaborative spirit that I've seen so many women in this field demonstrate. Thank you.
Thank you. Terry?
Thanks, Dr. Bond. That was great. And thanks, everyone, for the time to have this discussion. I think it is really important. And I think it has, for our standpoint of a company that largely is focused on technology and innovation around the devices that are necessary to diagnose and support treatment. In our way, we think about this in kind of three different strategic pillars, if you will. One is around the primary and referral care systems themselves. It's easy for us to be focused on the specialty hospitals and tertiary care. That's been the lifeblood of our business globally. But when you think about, and we all know this, that the primary and referral care systems are nothing but individual doctors, largely not as supported and trained, lacking many of the different things that they need to, he or she would need to deliver care. So we've really taken a concerted effort to think about primary and referral care, quote unquote, systems. And what does that really mean? Underneath that, of course, you have to think about a design that is, from the beginning, thought about as being sustainable, because that brings with it very different attributes in terms of what you're going to do, how you'll do that. You have to think about accessibility. We're clearly looking at ways that task shifting and site shifting, more virtual natures of which we can do primary and referral care can happen. So that's another key component of the design. And then, of course, not the least of which has to be affordability. And when we think in many markets, and I'm based in India, by the way, our sustainable healthcare solutions business, and as you hear in the name, even the word sustainability is there by intention. We are really committed to this idea that we help build systems that are sustainable. And when you think about models that we see across Africa or India or South Asia, there's a myriad of challenges to face, hard enough, as I said, at a tertiary level, but compounded by the things that we see at the primary care level. So systems design for primary and referral care is a very big piece of what we're focused on. And two examples that are actually quite small but give you somewhat the sense of how we think about this. In India alone, 42 million people have a heart attack. A large number of those will die unnecessarily, because they're not ever diagnosed until it's catastrophic, or they try to get to a healthcare facility but are, because of the terrible road conditions, especially in the urban centers, we see many of them die en route. So we have looked at ways that ECG, of course, to detect a STEMI event is really a critical factor, because at that point you can inject a thrombolytic and you can buy that patient another 6 to 8 hours. Very simple, very cheap approach. So we've looked at this, we've embedded in the ECG system actually the algorithms that can do that kind of diagnostics on the fly. So no one would need to know how they put the electrodes on it, guides them on how to do that. The signal is transmitted. And a partner that we work with in a bank of cardiologists, the cycle time is 3 minutes, they get an answer. A definitive diagnosis in 3 minutes. That changes the game for 42 million people in a country like India. Now, that means it's also very distributable. You don't have to be in a physical facility. This could be done, you know, on the back of a wagon. It can be done in the, you know, in a village. It can be done just anywhere. So this is another idea, which is it's portable. It can be done anywhere by anyone. Another example is actually when it comes to prenatal care. We all sit in this room, and it is, you know, such a shame that mothers lose their lives because of childbirth, or that infants don't survive that first 24 hours. Again, a third of those are easily solvable. We know how to solve these things. But one of the challenges is, again, the skills and the technologies are just not there to help identify those women that are at risk that should have institutional deliveries, or we don't have a view of this infant's risk at the time of birth, therefore we don't have a way to establish respiration or ventilation or thermal regulation. So another example of this, we built very, very low-cost models of things that we know how to make work, but we've had to embed more intelligence in the systems so that they could be used by less conventionally trained healthcare workers. We've had very big success with this, but we designed, for example, an ultrasound machine that is portable, it's simple to use. On the screen are tutorials in the language that that person is native to them. There's a reference image in anatomical terms. There's a reference image in the ultrasound sense. It's protocol driven. They only look for 10 things that are going to cause a mother a risk to her life to have birth in her village. And when you think about this, again, these are not hard things for a technology company to do. It's just that we never thought to do those kind of things because we had dwelt in, you know, much different environments. Then we partnered with other people, USAID, for example, and developed systems which we could do the integration with governments so that people across these systems, midwives, for example, could become participants in this. They could have a microfinancing capability. I know DIAH in Indonesia has looked at this when you have your population scattered across, how many islands, DIAH? 6,000? 17,000. So there's ideas around that, and so you build into the system integration of the ideas that are needed and the IT technology that will support the person so that they don't make a mistake, or that they have a quality guardrail, if you will, around them as they do these types of things. The second area that we're really focused on is the innovation of the business model, or access generally to the capital that it takes to put in place. There's lots of private money seeking tertiary specialty hospital investments. That's easier business model to make money at, to get your return. So that has been obviously the concentration of that. The primary referral care, though, is not a place that private equity wants to put their money. It's harder to have a return in a timely fashion. It's harder to understand. So here, I think, is what we've been looking at, is how we bring the blending of capital from the private sector with the backstop, if you will, of either a sovereign guarantee or an insurance, you know, or us in some cases. Because if you can make these models and scale them, they actually can provide a reasonable return. But a different business model is needed in order for that to be the case. Any primary care system that's completely funded through donor money, while is a wonderful gesture, is never going to be a very sustainable system. And I think that's why we should, none of us, think about this without a microeconomic that leads to a macroeconomic viability. And I think that's another big piece of what we're doing. And an example of that is the modernization of the Kenya healthcare system, a project that we took on where we constructed capital structures around it. We share a risk with them. We are on the hook for 7 years for diagnostic services across the 98 hospital system in 41 districts. And what's interesting about this is it allowed the government to upgrade and modernize in one fell swoop their entire system. Improving diagnostics, we all know, also improves your abilities to treat better, to spend less money, in fact, to treat, and avoid some of the catastrophic problems that end up in failure mode. So that was another big piece of what we do, and I think that is also still an untapped area for us to collectively think about how do we mobilize capital in different structures to solve the primary and referral care challenge. And the third area, which I personally feel very strongly about, and that's the skills development. Task shifting and site shifting, if we can put the right skills around it, is a way for us to fortify the primary referral care system, because we'll never train enough classically trained physicians or nurses and when you think about it, if you can narrow the scope and do a great job with the training, many people can do an excellent job. This has been proven in many different markets, but we're looking at this in 3 levels. We look at it from how do we help take high school students and bring them into the workforce. It's a great job. It's a lifelong job. It's a clean industry. We've started on projects. We started in India, in fact, with looking at this because there's 12 million high school students that graduate every year without prospects of college for affordability. Many of those, of course, are disproportionately girls who then are married off or, go into the unorganized sector. And that does not progress the generation that's going to come from them. So we're really keen on this idea that we can take high school girls, put them in the healthcare system. We've worked with the government. We've developed accredited programs for x-ray technicians, for example. If I contrast a very personal story, the first group that I met, very shy, kind of there because the village sarpanch or the village leader had nominated them to come. I go back, I just met with them so it's been almost 2 years. So they've graduated, they're in the workforce, and you can't, of all the things you get to do sometimes at work, these are the most meaningful. So, these girls walk right up, madam, and they're shaking your hand and they're looking you in the eye and they're proud about what they're doing. And you think about the fact that not only has helped the healthcare system, because now they have a very qualified new employee in the sector, but we've changed the outcome for that girl and for her, ultimate family that will come from her. And these are ways I think in the emerging markets will make massive differences to women as well as into the healthcare system. The other group that we're really keen on is about the frontline workers that are already in the system. Last night, in fact, we celebrated 13 of the frontline workers who are unsung heroines of the healthcare system. They do it out of their own convictions and passions, but they don't get enough credit, they don't get enough support. So we flew them here to Geneva for them to experience a World Health Assembly, but it's also for them to understand that they don't go unappreciated, and that support, and for them to go back and encourage other women and other young girls to enter in the workforce. I think this is a big deal, and all of them, by the way, if you heard their stories, are just totally remarkable what they've been able to do. And then the last area in the skills development that, again, we feel as, we're blessed in a large company like ours, we have lots of training capabilities for our own employees. Leadership training, communication, strategy development, data analytics, lots of things. So we're going to embark on how do we take the ministers of finance, the women in the ministers of finance, the women that are in the ministers of health, the women that are in the bureaucracy levels of healthcare systems around the world, how do we help enable them to get the next levels of skills that will make them more capable? Because at the end of the day, systems being designed by women, I am biased perhaps, but I think for the healthcare world, because 75% of the health is consumed by women and children, this inclusion will lead to more relevance, and more relevance will lead to more effectivity. So those are the three things that I think are really important for how we lead in this new world. Thanks.
Thank you. Beth, how would you respond to this question of what needs to work in a health system or in a non-health system for global health security?
Thanks, Loyce, and thanks so much for inviting me, and also for just this panel of amazing women, some of who I knew before today very well, and some of whom I'm just meeting for the first time, and those were incredible words coming from great experiences in the field. So I'm Beth Cameron, and I am currently now the Senior Director for Global Biological Policy and Programs at the Nuclear Threat Initiative. And I feel I should explain that the Nuclear Threat Initiative, NTI, has a long history of working on biological threats, whether naturally occurring, deliberate, or accidental. And actually, Kate and I share a mentor, Peggy Hamburg, who most recently in the U.S. government was the commissioner of our Food and Drug Administration, was the first person who held the job that I hold now at NTI. And she made it a practice that we would work in this field of catastrophic biological threats. We would work across the health and security sectors, bringing sectors together, focusing on issues like disease surveillance, like global health security, where we would be looking at how the threats that that our founder, Senator Sam Nunn, former Senator Sam Nunn, and philanthropist Ted Turner were really worried about, but recognizing that biological threats cross borders and naturally occurring pandemics are equally important and catastrophic as biological attacks or accidental events. So from our founding, we were looking at the systems approach and looking at how do we bring all of the sectors together to make an impact. Most recently, before this job, I was in the U.S. government as one of the people that had the absolute privilege to work with President Obama to launch the Global Health Security Agenda. And I just want to note one personal reflection, which is that when the first troika, the first three-party leadership of the Global Health Security Agenda was created, we looked around at one point and realized that the ministers were all women, and most of their senior staffers were also all women, and that was Finland, Indonesia, and the United States. And some of those really courageous commitments that were made very early on in that effort were made by women leaders who continued those commitments, by the way, and that's just been absolutely heartening to see, and it's heartening to see it continue, Dia, with great leadership from you and your minister as well. So I just want to take just a couple of minutes to share a few reflections on the answer to the question, which is what are three of the things that I think are essential when looking at the broader health system, and then how health security fits in it. So what needs to work, I think, is the question that you asked. So I think first and foremost, you need to have coordination amongst the sectors. And we say that a lot, so I'll say it. We should all talk to each other, and I think we are all talking to each other. And in my 15 years of experience in this field, that has gotten so much better. We are doing a much better job globally and in my own country, in the United States, of working across sectors. And I've seen that just improve regularly every single year. But I do think that there's still some challenges that I find that are still out there in bringing in the finance sector and the security sector, as well as some interesting silos when you look at the broader health system world and the health security world and then the development world. And I find that while we're all talking together and we have some similar priorities, one of the things that's meant, and we're coordinated, what we're missing often is synergized action in the field. And so I think that in addition to coordination, we need synergy. And in order to have synergy, we need to have some common targets and approaches. And that means more actual tangible efforts in the field, like some of the efforts that we just heard described, that actually very purposefully bring those sectors together and then measure using the same tools. And I think one great advance in that has been the bringing into effect of the International Health Regulations Joint External Evaluation, which takes the international health regulations and breaks it down into targets, but very purposefully when an independent assessment of a country's level of capacity to meet the core capacities of the IHR, when those evaluations are done, they're done by bringing together all of those sectors. And we have done a lot of work, over 40 have been done, but the next step, financing, follow-up, getting the development communities that have funding and the finance ministers in the country that are responsible for the budgets, getting those people together to the table, that we still need some work. And then bringing in the private sector, which has made enormous gains through the GHSA Private Sector Roundtable. How do we bring in the private sector in a much more rigorous and routine way so that we don't have pilot projects, we actually have a practice of doing this over time. So I think coordination and synergy are important. And then finally, action. So I would say that we've made a tremendous amount of progress over the past several years, but there's still a lot of work to do, and at every World Health Assembly, something unexpected seems to happen, and I certainly didn't expect to be at a World Health Assembly again in 2017 talking about an ongoing Ebola outbreak in a place where the world was really concerned. While the Democratic Republic of Congo has great capacity to handle Ebola and has dealt with many outbreaks in the past, the situation where those outbreaks are occurring is very concerning with respect to displaced communities and people, and I think speaks to again the need for the communities that are interested in migration, broader health systems. How do we treat people, including an enormous number of women and children? How do we work with those communities as we're working at building systems that can actually prevent, detect, and respond? And so I think that just highlights for me that we still have an enormous amount of work to do. And I'll just close because the DG, Director General Chan, just made her remarks right before, opening remarks before we came here. And she said, what gets measured gets done. She said it in the past. Many of us at this table have said it over and over again. My good friend and mentor, Scott Dow, who was at the CDC and is now at the Gates Foundation, said it a long time ago when it wasn't popular to say it. But it's true, and I think we all need to be even more rigorous than we are about measuring the results in our own countries, sharing those results, and really building on them. So, thank you.
Thank you, Beth.
Thank you. So I'm Jennifer Esposito. I'm from Intel Corporation. And just to sort of start off and give a little bit of background, we often get the question about why Intel is interested in healthcare and why are we working in this field. And, we are a technology ingredient company. People know us for processors that sit inside computers. But I think from the perspective of health and life sciences, you'll see that our capabilities, our technologies are really across the ecosystem in everything from large medical imaging equipment to small devices. And so for us, trying to really understand the way that our technology capabilities can be used to leverage further digital transformation in an industry like healthcare is really where we want to work. And that's what my team focuses on. So in answer to your question, Lois, and sort of dovetailing off of what Beth was saying, I think there's two things that I wanted to mention as being necessary. A lot of times when we do digital health projects, we noted that it's really important to understand the underlying infrastructure in a country or in a region really before you decide to go off and implement either a product or a technology or even a pilot program. Because that underlying infrastructure really is going to be the make or break of the long-term scalability and sustainability of any project. And so I think it's really important that we take into account that underlying infrastructure. And that can be everything from, we talked about roads and transportation, but when you start to think about digital solutions, it's really about the information and communication technologies that are available to leverage. And once you understand where those gaps are and you really build that roadmap out, you can start to do a process map almost of where you want to put those capabilities in place. The second thing I wanted to talk about was the role of the private sector. Beth started to mention that. I think one of the things that we've learned participating in the private sector roundtable for the GHSA is that there's really an interesting opportunity for the private sector to mobilize resources across multiple different industries. And so if you look at the makeup of the PSRT today, you'll see that it's not just healthcare companies. We have companies related to energy and transportation, supply chain, logistics, food and beverage. And so it's really important that you really consider, even in the private sector, across industry capability and leveraging the expertise that can be brought to bear there.
Thanks very much. Dr. Martin.
Thank you, Loyce, and I just wanted to first of all just thank all of the co-sponsors for this event and for inviting me to be here with this esteemed group of women up here as well. And I wanted to start talking a little bit about, I've been working in polio eradication for over 17 years, and in trying to, when we're at the very end and we say we're this close, I think one of the main things we've realized, and really trying to make sure that we can reach every child, has been how we deliver vaccine to children in a community. And it was very quickly seen, well, not very quickly, but over the decades, it was quickly seen that the importance of who approaches a door with a vaccine is very important. Who delivers the services to a family? When it was men that were coming in, women were not answering the doors in Afghanistan and some areas of Pakistan. And we were having high refusal rates. We were not reaching the children. So it became very important that women had to be involved in this and had to lead this and become frontline workers in many of the communities. And around Peshawar, in the last few years, it's been very traumatic, is that we have seen that there has been killings of people who have been delivering vaccine. And there's one specific story I know very well. It was a woman who was delivering vaccine, and she was actually shot and killed vaccinating. Her sister then took us to see the spot where her sister had been killed, and she picked up the decision that she was going to then start doing it. And so she continued it, because she says it's important for all of our children that we don't get paralyzed and that they have long lives. So the value and the importance of having that important role in this community, being able to deliver vaccines to families and understanding the culture and the dimensions of this is really critical. In thinking a little bit about the polio eradication efforts, which are very much a very vertical program driven to eradicate a disease, it hasn't always been the strengthening of a health system with it. And I'll get into a little bit later, but to note that it has required, to be able to get where we are, that all countries have had to have strong leadership and governance in countries to be able to move this forward, and the political commitment. And we use that word quite broadly, but in terms of presidents setting up national task force to have accountability with their states or with their provinces, and the importance of having that sort of a structure for an effort in a health system delivering health. The other is, as Beth mentioned as well, is the importance of the multi-sector, the private-public partnerships with the Rotary Foundation, with Gates Foundation, with international organizations and countries, has been so critical in being able to move this forward, and everybody leveraging what their strengths are in bringing to the table and being able to do these efforts. The health financing, I wanted to hit on a bit, because this has been very important, and there were areas, as I've also heard today mentioned by TERRI, that for sustainability, it did require, for example, in Kano State, it was the Dangote Foundation, which is from that area in Kano State, working with Gates Foundation to come up to say, okay, if this state can meet these criteria and meet these monitoring measurements, then Dangote would put money in, Gates Foundation would put money in to strengthen the health system. So how do you think about innovative ways to finance the health system is really critical. Now, we do know that health systems are very important, and as I said earlier, with polio eradication, not having a strong health system and trying to eradicate a disease has been a hindrance in many areas, and because we don't have the immunity up that would have been delivered through a strong health system if it was there. If the vaccine was available, it was vaccinating kids. But at the same time, as we saw with the Ebola outbreak, that having a health system where over decades there had been resources put in to strengthen in Liberia, for one country as an example, but was not able to detect Ebola virus, because you need to have that public health infrastructure with that. And the importance of these two working together. We've talked a little bit about the importance of the workforce. And this goes both for what's in a health system, being able to detect, being able to monitor trends over time and understand what's happening, having strong laboratories that can quickly detect point-of-care tests or diagnostics that are quickly available, and then the surveillance. And this is the disease detectives on the ground, the front line, in the communities, in working with healthcare facilities, and being able to respond rapidly. And both of these also need strong information systems. We needed to be able to link laboratory data with clinical data about a case, a death, to know what were the results and how to understand where the outbreak was spreading and where it was going. So the importance of bringing these pieces together for the detection and response are critical. The prevention piece comes through the deliveries at health systems, be it through outreach or at an actual mortar and brick facility. These are vaccines, these are antimalarials, insecticide-treated nets, antibiotics. But the importance of having the prevention piece in place, and this again requires the human resources to deliver these and access to the needed interventions, the medical countermeasures. And we saw, even with these Ebola outbreaks again, that most services were stopped. There were not the healthcare workers. People were afraid. They closed down. They weren't delivering. Pregnant women were not able to deliver in hospitals. They weren't able to give vaccines. So the importance, again, of having that work together with having that health system to deliver the prevention strategies to be able to treat. And I wanted to end by just talking about the importance also. So we've talked a lot about what's needed within a health system in a country. And you talked a little about what's needed externally. And I think what's needed externally is that ability that if an outbreak, if something occurs that we need for health security out of control, we need to have either something regionally or globally that can be there to be able to surge, to have that capacity to surge. And we've talked a lot about the importance of the World Health Organization in having the capacity at the global level and working collaboratively, but also regionally and across country, what's needed to have that collaboration to be able to respond if things get out of control across health systems and sharing information. Thank you.
So the beauty of speaking last is that you can quote your fellow panelists, but then again, everything has been said. I think what is important in a panel like this is that why is it important to be leaders as women leaders? Because leaders can lead by example. That has been said so many times. But as you mentioned, Rebecca, women have a special way of getting into you. If you don't listen, we will force, and we will talk until you listen. And we will lead until you follow the example. So in my line of work, in the past 7 years, my focus has been to harness young women leaders, young leaders at first. But it turns out that the ones who have the courage to lead are mostly women. And not only to lead, but also to do. They are more willing to go to the hard-to-reach areas in the 17,000 islands that we have in Indonesia. I recruited health workers, human resources, just recent graduates of health fields, and more than 50% of the recruits are women. So if I have one team, only one man with 5 to 6 women. At first, the connection between deploying health teams and sending new leaders to hard-to-reach areas was not visible to me. It was not very clear. I felt that I'm put into two directions, opposite directions. One, setting examples, actions, and one is the health security field. We talk about measuring measurements. We talk about joint external evaluation, implementing the IHR. But as Indonesia lead the global health security agenda last year, the connection became visible that there will be no health security unless there are actions on the ground. Continued, well-planned, well-measured actions on the ground. And the ones who can ensure that it can happen are the health workers who are being deployed, who knock on doors, and who continue to educate the people in community level. When we talk about health security, I think the tendency is to believe in the myth that health security, public health threats will not happen in my country. It is impossible that health emergency can happen in my country. That is the myth. Health security seems something far away. It can only happen if I'm in Indonesia. It can only happen in Africa. It can only happen in Korea, but not in Indonesia. That is the myth, and that is the biggest challenge that we have to face, and what we need to educate the public back home, in my home. Because people awareness of how close health security actually is virtually zero. Now, with Indonesia's leadership in the global health security agenda, we can educate the public easily, because then we can have news articles of meetings in the World Health Assembly talking about the Ebola outbreak or the MERS coronavirus. The examples become clearer, and why Indonesia needs to be involved, actively involved, and lead. The fact is, we have experienced few close calls in Indonesia. With Ebola, we have several suspects. With SARS, with avian influenza, and the list goes on. But one thing that I think women can do also, women leader can do well, is also to communicate. The reason that the global health security agenda under the leadership of Indonesia last year made a leap, I think mainly, and this is not to make the gentleman in the room feel bad about it, is because the minister is a woman. The health minister is a good leader who I follow by replicating her leadership, and it makes it more easier. But then communication is also very important in tackling the challenges at national level. When you go above to the regional and global level, then in my perspective, things get more easier to communicate and to comprehend, because we meet with people who share the same concern, who wants to achieve the same objective. So measurement and the commitment, the commitment to be measured with the joint external evaluation is easier to be achieved. I don't see the only gap that I see throughout this 2 or 3 years, the very short period of time that Indonesia is involved and I myself is involved in global health security, is that different countries are at different points right now in implementing either IHR or in their knowledge of global health security. For example, yesterday in the meeting, in the global health security agenda meeting, we talk about tracking commitments. We talk about how to convince finance minister that there should be a healthy budget readily disbursed for global health security. I went back after that and I said to my minister saying that it is still a challenge for Indonesia because we are not at the same wavelength yet with our Ministry of Agriculture. And I imagine that challenge is shared by any country, by more than one or by more than 5 countries. So it is going forward with this progress that we have in global health security. I see it as an impending issue that we need to address in the global health security, but also in a bigger group in the WHO. We can track progress in, for example, the National Action Plan of AMR. How many countries have completed the National Action Plan on AMR? How many are not? I think from that picture alone, we can then summarize that not every country are at the same level of implementation. And that is one challenge, but also at national level, needless to say, it is a challenge communicating global health security to 17,000 islands, 255 million people. But we embrace that challenge and we keep on moving forward to that. And I think I would like to close by encouraging everyone to, when you go back home or back to your respective jobs, find those who you think will be the leaders. I've seen many in such a short period of time, and they become women leaders in their own field of expertise, and it is very fulfilling. I believe all of us here share that same fulfillment if you see young women professionals and continue to become the leaders of their own, and push for consistent action on the ground. I think we will not have anything to report unless there are actions, and actions means infrastructure, not only the roads, not only the electricity, but also if in our fields, in health and in welfare in general. I think we have to replicate the leaders that are in the that reside in the communities. That is very important, and I believe that will be one key aspect to resolve the national challenge that each of us are facing. Thank you.
Thank you very much, DIAH, and to all of the panelists for offering some really interesting themes I think we can come back to in additional Q&A. Before we continue, though, with those questions, I wanted to acknowledge the presence of the Honorable Minister of Health from Uganda. Thank you very much for joining us. Those of us in the room have your bio in front of them, but I know that Dr. Jane Singh was appointed Minister of Health of Uganda back in June of 2016, and so happy anniversary to you as Minister of Health. She has a number of other positions that she has held, and she is a pediatrician by training, and so we appreciate her medical background in terms of what she brings to this space and discussion around global health security and health system strengthening. And finally, and maybe most importantly, she's another women leader in global health, and so we welcome you, and we would love to invite you to invite remarks, should you choose now, or perhaps at the end of the session. You're welcome.
Well, it is a terrible ambush. I thought I was going to sit down and acquaint myself with the environment and with the people, but yes, well, first of all, allow me to thank you for this invitation to come and share with you my perspectives on enabling global health security through health systems. From yesterday, we have been having meetings on global health security, and I thought it was very important that I also share some of the perspectives that we hold as a country in Uganda. So with the world now a global village, A disease threat anywhere can mean a threat everywhere. And this was clearly demonstrated in the outbreak that took place in West Africa and the various outbreaks that continue to take place. With people traveling more, a disease can be transmitted from one continent to others in less than 24 hours. And global health security, as defined by the World Health Organization, as the activities required, both proactive and reactive, to minimize vulnerability to acute public health events that endanger the collective health of populations living across geographical regions and international boundaries, is a critical issue that we must all pay attention to. There is need to develop health systems that prevent avoidable epidemics, detect public health events of national and international concern early, and respond rapidly and effectively to detected public health events to contain them at the source so as to prevent international spread and interference with travel and trade. The International Health Regulations 2005 provides us with the framework for enhancing global health security and preventing the spread of disease across international borders. It is a legally binding instrument for WHO member states, and it provides a framework to prevent, detect, assess, and if necessary, provide a coordinated response to events that constitute public health emergencies of international concern. And countries are required to build specific capacity to comply with the international health regulations. The Global Health Security Agenda, which is a supporting agenda for countries including Uganda to accelerate this attainment of the core capacities and to become IHR compliant, is a very vibrant and welcome agenda that has supported many countries including Uganda to build our capacities to be able to prevent, detect, and respond. Uganda became one of the global health security agendas very early in 2013 when Uganda was a pilot country for some of the core capacities. And Uganda is one of the countries currently that has been spearheading the global health security agenda. Core capacities required to ensure global health facilities across include enabling legislation, the public health workforce development, laboratory strengthening, antimicrobial resistance monitoring, strengthening immunization services, real-time surveillance and reporting, biosafety and biosecurity, surveillance of food safety, zoonotic, chemical, and radionuclear events, preparedness and response capabilities for all public health events. We can only achieve and sustain these capacities if we use health system strengthening approach. This approach, which enables coherent improvements in the 6 health systems building blocks, help us to build resilient health systems that are a prerequisite for effective prevention and response to public health events in a manner that enhances global health security. Health system strengthening not only enhances global health security, but also contributes to improvements in other health aspects, like reduction of maternal and child mortality, elimination of vaccine-preventable diseases, and availability of a health workforce that can support delivery of several preventive and curative services. In Uganda, we started implementation of the International Health Regulations in 2007 when it came into force, with support from different partners, including the World Health Organization, the Centers for Disease Control, USAID, DITRA, the Global Health Security Agenda, and AFINET, among others. Over the almost 10 years of implementation, we have made good progress, but this progress was only enhanced by the Global Health Security Agenda. The Global Health Security Agenda has provided us with critical support in building the international health regulation core capacities and supporting other health systems elements. Allow me to share a few things that have worked well in our efforts to strengthen health systems and enhance national and global health security. We have worked on strengthening the national laboratory system. We have established reference centers at national and regional levels, several of which are already internationally accredited, and built a national specimen reference system to the reference laboratories, which not only enables quick confirmation of epidemic threats, but also supports surveillance and confirmation of other diseases or conditions, including HIV, especially in infants, tuberculosis, malaria, and neglected tropical diseases, among others. We adopted the implementation of the international health regulation through integrated disease surveillance and response, and we have embarked on training in-service health workers and strengthening integrated disease surveillance implementation at district health facility and community level. The health workforce developed at national and subnational levels during in-service training, as well as in the field epidemiology and laboratory training programs, support prevention and response to epidemic threats, but also support reduction in maternal and childhood deaths. The immunization system has been strengthened and are increasingly reaching more children with routine vaccines, but also supports vaccination responses to epidemics like the meningitis epidemics. An electronic reporting system combining mobile phone technology and web-based reporting has been established to enable real-time reporting from health facilities and districts on notifiable public health events, as well as other public health priorities in the country. And data generated enables not only real-time detection and monitoring of public health emergencies, but also monitoring of coverage and effectiveness of other public health interventions. Furthermore, we have made efforts with support from our partners to strengthen the capacity of our national medical stores to distribute medicines and supplies in a timely manner to all districts and health facilities. The same system is very instrumental in ensuring medical countermeasures are distributed to wherever they are needed in case of emergencies. And with support from the Global Health Security Agenda, we have established a modern emergencies operations center, and we are in the process of establishing a National Public Health Institute. Ladies and gentlemen, meeting the requirements of the international health regulations is a challenge that requires time, political and technical commitment, as well as significant investments of resources. The regulations are broad and place greater emphasis on the responsibility on countries to build required capacities and systems for detection and control of public health risks. However, from our experience, building resilient health systems is necessary if countries are to achieve and sustain their capacities to prevent, detect, and respond. And I believe that the Global Health Security Agenda has provided a good platform for this to be achieved. Pandemic threats and response to large scale can stretch health systems and have devastating effect and impacts on the public health and country economies, as was the experience in West African countries that were affected by Ebola. Thus, a system strengthening approach should be adopted as we build on the capacities of countries to be able to detect, prevent, and respond. As women leaders, we have a big role to play in ensuring that this critical issue is prioritized, allocated adequate resources, and that health system strengthening is realized for the benefit of all the people, especially women and children who are the vulnerable groups. As I conclude, I would like to inform you that from the 25th to 27th October, Uganda will host the 4th Annual Global Health Security Agenda High-Level Ministerial Meeting to discuss and share and learn from each other's experience in implementing the Global Health Security Agenda action packages, as well as integrating global health security actions into relevant national and subnational programs in a sustainable and all-inclusive way that is health system strengthening. The focus of the discussion will be building country ownership and engaging communities, non-governmental organizations, the private sector, academia, development partners, and other agencies that support the global health security agenda. And the objectives of our meeting will be to build country ownership and engage communities, non-governmental organizations, and other partners, strengthen multi-sectoral collaboration, and promote integration of health security into routine, national, and subnational and community programs, as well as to encourage national governments to develop frameworks to engage communities and the private sector, and to learn good practices for enhancing and sustaining global health security programs at all levels. We hope that this meeting will agree on how to implement the Global Health Security Agenda action packages within the framework of health system strengthening, integrating the Global Health Security Agenda into routine health development agenda, and that the best practices will be adopted for sustaining global health security programs, thus enhancing national and global security. Thank you so much for listening to me.
I'd like to thank the Honorable Minister again for jumping right in and offering us her take on the challenges and opportunities with the Global Health Security Agenda. And it sounds like she invited those of us who are here and who can attend to join her in Uganda this October for the high-level ministerial meeting. And so thank you very much for extending that invitation. We welcome partnering with you and other governments on this agenda. And to that end, I'd like to, with you all's permission, ask a few more questions of our panel before a couple of them I know have to leave for other events. And I'll just give you a preview of what I'd like to cover over the next several minutes, the next chunk of time we have together. One is around this idea of partnerships. The other is related to looking more deeply at health workers and how we can better support them. And then finally, this theme of connecting the dots across gender issues and looking kind of at a higher level across development is something I'd like to explore as well. So first of all, to Jennifer, I have a question really around partnerships, and you as well as others spoke around the private sector roundtable. And so I wanted to really ask whether or not you are able to issue a sort of call to action and tease out some incentives. What's in it for groups to come to the table? You know, why should they join you and other corporations in this effort?
Yeah, I think that's a great question. I mean, we had a great session this morning talking a lot about private sector interaction with the GHSA, and we participated yesterday in the steering group meetings. And I think the call to action, or sort of the invitation that I hope inspires other corporations to get involved, is really around the ability to work across industries to drive some of these action packages related to the GHSA. I think if you look at single industries, there's really no way to resolve all of the gaps that are potentially there. And I think this is a unique opportunity for the private sector to work together, to get to know each other better and find new synergies across the different corporations that can be involved. I think standalone corporations and solutions can solve individual or very specific narrow problems, but I think when you put together the sum of all of the parts, you have a much better solution, and you also have a much better chance at building out that infrastructure that I was talking about earlier, and really building a foundation and almost a framework to move forward. So with the private sector roundtable, we've had some really great opportunities in our working groups to interact with the GHSA, with some of the countries that are participating, in particular countries that are contemplating or about to go into the joint external evaluations. And our technology and analytics working group has really been working very hard, particularly around taking the information coming out of the JEEs and putting it into a usable format for both the countries to assess where they are, and, you know, more broadly speaking, to look across all of the countries to understand where the potential gaps are. And I think that ultimately will help us all identify specific projects where different parts of the private sector can engage and help resolve and execute on some problems.
Thanks very much. Kate, you and others talked about people on the front lines, and I want to come back to that because that was definitely a recurring theme that I heard. Really thinking about the role of frontline health workers, and not just those in healthcare, but how can we best support, mobilize, protect health workers across the health spectrum. So looking at healthcare workers, but also lab techs and people who focus on supply chain logistics and in other areas of health. Can you talk a little bit more about reaching those professionals?
Thanks. I think clearly identifying the tools that will help them do their job is a critical part of this. And as you know, as we look, particularly in the area of substandard and falsified medicines, the basic tools are still quite nascent. In fact, you know, the examples we have from health security, prevent, detect, respond, these are all relatable to the area of supply chain. And we need to kind of consider what we need to do with respect to ensuring quality. So with prevention of harm to patients due to supply chain issues, we really have to keep bad products off the market. And frontline health workers are often trust that what they have to dispense and deliver is actually going to do what it's supposed to do. When in fact, in countries and areas where those supply chains are not robust enough, that actually isn't always the case. And we can see the harm to patients then that comes from poor quality, and we can also see the potential contributions to resistance, as we have with malaria and TB, often in areas that are remote and hard to reach. We also need to try to strengthen the private distribution channels, because we see often that they do tend to be more robust and can deliver quality assured medicines more readily. Improving procurement practices. So that's something that happens before medicines reach the front line, and is the responsibility mostly of national governments, also procurement entities. We also need to be able to better detect when we have problems in products. And this is an area that requires a lot of ingenuity. And there's some interesting innovations in technologies that, as they advance, could better be deployed to help border inspection and surveillance, for example, or even pharmacy providers, track and trace technologies and things that will be coming. And we're actually doing considerable review to really define and determine what's appropriate to use in what settings, for what purposes. A lot of use of mini labs and other more mobile types of approaches to begin to screen and then confirm medicines before removing them from the market, and then obviously taking them off the market. I think what's really critical here, again, is to just reinforce the message that it really takes a whole system, and it takes communities, and it takes enforcement officers. It is a very widespread effort. We really need to be looking more at localized approaches for this type of coordinated response, particularly in areas that we may see as kind of hot zones for poor quality medicines. I think, there are efforts at the global level, Interpol, for example, and others that are trying to generate this type of cooperation, information sharing, enforcement, taking products off the markets. But ultimately, I think it gets down to the health system and health workers and having robust regulatory oversight, having well-trained pharmacists, having practitioners who are aware and understand that this may be a risk, and educating communities, patients, consumers to really be vigilant and to be able to see sort of what's happening down the road. So I think these are all really critical components, and I think should sound very familiar in the global health security context, but with a particular dimension and focus on the products and the safety and quality of the products. I think it also, points to the need for a greater degree of cooperation regionally, sub-regionally, globally, in terms of information sharing and response and alert. To that point, I think Uganda has demonstrated a lot of leadership in actually the drug authority reporting to the WHO when there are incidents of products that are found that have no active ingredient. So it really does require, again, a mobilization, and I think this is a key area that we can't forget in thinking about both frontline workers, but also the health systems more generally.
Thank you, Kate. I'd like to direct the next and last question from me to Beth, and I'd like for you to speak about this intersection of women and global health security with other issues. I think TERRI and a couple of others really pointed to the education opportunities, the economic development component. No pressure, get ready. But help us tie it all together, because as we really think about this era of SDGs and really responsibly sort of investing in development on the ground, people are not organized in this way. People are people, and they come with a lot of different things. And so can you talk a little bit more about how we can connect the dots?
Yeah, no pressure. There's some. I would also just say I know that that DIAH has had a lot of experience with the SDGs and the Millennium Development Goals before them. So please feel free to jump in. So I am not a development expert, and I'm going to start this question by saying that I'm not a development expert, but I found myself throughout my career in situations where I had a large pot of money in the U.S. government in the security sector, in biosecurity, biosafety at the Department of Defense, which worked really collaboratively on global health security with Uganda on the pilot project that Minister ACENG mentioned. And I found myself working in a situation where development was really, where the development sector had funding for other things, but the security sector sort of had a big pot of money and wanted to spend it. And I think that is also the case, and has been the case for many years leading into the development of the SDGs, where there are so many different donors with different agendas working in countries with that funding. So what I would say from my own personal experience is first and foremost, having to when we are working in our field of global health security, and we want to look at how it fits into the broader sector of development and health systems more generally in the health world, you need to first and foremost know what's going on in the country, and you need to also understand who else is at the table before you start your plan. And I think we all know that in this room, and certainly at the World Health Assembly, we spend a lot of time talking about these things. But I think that some communities that don't come to the World Health Assembly, that have an enormous amount of funding, are not necessarily always thinking about that. And so I will share just really quickly, and then I'll touch on the gender issues that you wanted me to really tie into this as well. I'll share a quick vignette, which is that almost 10 years ago, not quite 10 years ago now, the CDC, and I'll give Rebecca and her team a ton of credit here, approached me and some of my colleagues at the State Department, and then when I moved into the Defense Department, to talk about this, to really be open and honest about the funding that we had and how it was being spent for biosecurity, but within the context of the public health system, and to say to us, look, you really need to work with us and make sure that you are working with our development colleagues and with the right people on the ground to make sure that what you're doing is strengthening the broader health system and the broader healthcare system in which you work. And over the last 10 years, we have transformed the way that funding goes out of our government, and culminating in the work in the global health security agenda in our own country to actually measure against the same yardstick, and to be able to work in countries like in Uganda to make sure that that capacity is sustainable and that it works for the security sectors in both of our countries and also for the health sector. I will just say this about gender, women, and children. Another vignette, which is as we were working on the global health security agenda, we found ourselves in numerous situations where we were talking about threats, as Dia mentioned, that were not first and foremost on the country's mind or on the minds of our ambassadors in those countries. In the case of public health, they had other programs they were worried about, and rightly so, that are killing people, women and children every day. Maternal and child health programs, HIV, AIDS, our PEPFAR program, tuberculosis, and every other health concern and NCDs that we care about here at the Assembly. And what we found was the absolute most effective way to work across communities to make sure that we were serving the most underserved people in these countries, which tends to be women and children in almost every case, is that we drew together our entire team in our government and then the entire team on the other side and said, how can the funding that we're bringing in for these specific purposes also bolster the gaps that we have across the whole system? And there were some tremendous examples. The most heartwarming examples in the GHSA for me were the examples where the countries were really able to say, and our ambassadors were able to come to us and say, your funding, because it wasn't tied to a disease threat, it actually was able to help us pull together all of these other funding streams that were, so that we could get to sustainable lab capacity, which all of the programs, by and large, are funding, so that we could reach a population by adding a service or a training out into a place that we didn't have it before, and by utilizing it to really create the workforce that's at the backbone of all of this, which has been mentioned by almost everyone on the panel. So that doesn't give you a perfect answer to your gender question, but it gives you some of my experiences about how we can work together across the
I appreciate it, Beth. I think you had one of the harder questions. Yeah, I know. You're going to get me back for that, I'm sure. Dia, do you have anything to add to that, please?
I think reflecting on my experience with the MDGs and with the SDGs, of course, I will echo Beth by saying that I am not a development expert. We are going through a development action. But based from my experience at least, I see development means sometimes or many times taking sides. When you choose, you make your priorities, then you are taking sides. Global health security or gender or women and children's health are by no means competing with one another. They are equally important. And if you refer it back to the SDGs, they are the interlinkage, they are intertwined with one another. Because one cannot be achieved if the other targets or indicators are not achieved. You cannot claim you achieved the SDGs unless you have checked out all the indicators. You have measured all the indicators. So gender or women maternal health, I see in this year's WHA, we talk less about maternal and child health, and we talk more about global health security. Is it wrong? No, it's not wrong at all, because everything falls under the health system, the quality health system that is talked about and laid out perfectly in SDGs 3. I say it's perfectly laid out because I negotiated that. So it's biased, I know. But it's in the end, you choose the area of expertise, you choose the path, and there at some point you will find all those different points converge. And I see it now happening with the global health development, like the convergence or the meet-up between Geneva and New York, and in AMR, and next year in TB. this is a very optimistic outlook of global health development. And I think gender is a major part of it, because increasing the increase of women, status of women, I will bet my career on it, that it will increase the health profile of a country. Thank you.
Yeah, well said.
I knew you could answer that question better than me.
So I recognize that you all have been sitting with us for quite a while, and thank you for your patience. I also recognize that a couple of the panelists might have to scoot off, and so I will beg their forgiveness on their behalf, but thank you very much for your time with us today. We appreciate your insights. And for those of you who can stay, I hope that's more than one. I can't answer any of these questions. But I did want to invite a few questions from the audience, including those online. I don't know if anyone's watching online who wants to submit a question or has submitted a question, as well as a couple of folks in the room. So, people in the room, raise your hands if you have questions. Thank you very much, sir. Go right ahead.
Thank you. My name is Andrew Jones. I'm the head of partnerships at an organisation called THET in London. We have an interest in health workforce development. Slightly alarmed that Terry's just walking out of the room because I had a question or an observation for her. But I'm sure others will be able to answer. One of our particular focus areas, amongst others, in workforce development is in biomedical engineering and technology. So these are the folk who fix the equipment that people like Terry supply, and keep hospitals running, keep them health facilities running, keep them safe. In sub-Saharan Africa, only about 10% of all biomedical engineers and technicians are women, although 25% are represented in the new intake for training. But the problems that they identify in their professional lives are lack of career development opportunities, lack of confidence and lack of voice, and a lack of role models as well. So we're working with colleagues to create a network of women biomedical engineers and technicians in sub-Saharan Africa to help address some of these issues. And so what I wanted to ask is, do you have thoughts about how you can create an environment for women to flourish in what is actually a male-dominated and under-resourced profession?
Other questions that we can sort of cluster? No? Okay. If you are ready and willing, please go ahead.
Well, first of all, I'd like to congratulate you on this effort, because I think it's absolutely critical, and as we see more women in fields like biomedical engineering and science more generally, we are going to see a change in the way things are done. We'd be very interested to learn more. USP actually in 2015 created something called Women in Science Exchange, WISE, which is really generally with the same intent to try to mentor and empower women professionals in science in Africa, many in the areas of regulatory science and pharmacy. And I think it would be tremendous to understand better how you're working and maybe where there are areas to join up. Thank you.
Yeah, I'll just offer. I'll offer a personal reflection on this as a scientist myself, but not an engineer. So, but I'll take another field too, which is I'm a science professional with a health background and a cancer research technical training in national security, and I have been surrounded by I was surrounded by men at the Department of Defense in my career, and when I came to the National Security Council, every single person in my four-person leadership chain until the president was a woman. And I will say that greatly, having actual role models, so not just having a program to develop the leaders, but actually having some leaders in that chain that you can look up to and really see how they lead, and that it's possible. And I'm definitely not a literature expert here, but for sure it makes a difference for women who are looking at a field and looking at whether they can want to stay in the field or whether they want to exit and pull the parachute on that field, if they feel like it's a field that women can A, flourish in, B, move up in, and then C, that it's a field where some issues that are unique to women, for example, getting pregnant, ability to have children, that it's a sustainable environment for those factors, that those are also at least built in to the program. I worked in a National Security Council staff where we had women at the top with small children, and there was a moms group, and it made a huge difference in the retention of women for a very long period of time. A huge chunk of our Ebola task force at NSC was women, and we had a woman who was pregnant all the way up until she delivered, working on the task force, and we just made it work, and that was encouraged. So without any good literature or science, as a scientist, I feel very uncomfortable giving you information without science to back it up. But I would say that I think that if you have a training program and there aren't any women in the pipeline, that you will not experience the retention that you want. But congratulations, that's a fantastic effort, and I too would like to learn more.
Thank you both. And I did, there was one more question in the room, which I'll get to, but I did offer an opportunity for people online to ask questions. So just wave, gentlemen, if you happen to see any come through. I'll move on to Katherine.
To the two surviving panelists. And it's looking, my question is for Beth, actually. I appreciated both your comments. Beth, you mentioned as part of your comments that much of the funding within the global health space is earmarked, and particularly we know the US government's funding is earmarked, and yet DOD funding was able to come in that was not as earmarked, and you were able to do some really good things to add value to what was going on. Can you tell us a little bit more about what you were able to do and the impact it had?
Yeah, absolutely. So one of the facts that we don't talk about as much, because the Global Health Security Agenda is really a global phenomenon now. The U.S. launched it, but it is truly global, as you've heard today. But one of the things that we don't talk about as much in international settings is that one of the reasons that we had the conversations that ultimately led to the discussions with the WHO and with a number of other partners about the potential need for such an agenda, one of the driving factors was the way that the U.S. government funding is organized for health security. And we don't have one piece of legislation that governs global health security, and we don't have a coordinator the way that we do for malaria or HIV/AIDS. And because of that, there are five different appropriations in our country. That's how our Congress gives us funding across different pieces of the government. And we found ourselves working together and having great coordination. I can tell you how many teleconferences we had on a regular basis, but we didn't have any synergy. We weren't necessarily working to the same goals in the same countries, and that got challenging. And it was very challenging when making the arguments that some of the components needed more funding, because the pieces of our government providing the funding were totally different. So when I said that the DoD money was more flexible, there was just more of it. The budget for the Department of Defense, for example, when we launched the Global Health Security Agenda, was about $300 million a year for cooperative biological engagement, which I absolutely believe is very important. The budget for other things in the defense programs that look at nuclear threats and chemical threats, well, nuclear threats for sure, was much higher. But the funding at CDC for this was around 70 million, and the funding at USAID was about the same, and the State Department funding was less, and the USDA funding was almost zero. And the FBI participates in linking law enforcement to CDC, and they were taking contributions in kind from other parts of our government. So we wanted to get everyone together to actually look at how much money do we have, where is it, what are the common targets, and how can we do better? Because we knew we weren't going to be able to change the system in our country at the time to say, hey, let's just put it all in one pot and figure it out. That our system wasn't set up to do that. And so instead, we brought everyone together and tried to find a way to work together. And it was not simple to get that to happen. And so what resulted from that, you heard the minister from Uganda talk about some of the most successful examples we had, but they were in places like Uganda and Kenya, and Vietnam is another fantastic example where the Department of Defense and CDC came together. But now we have examples all over the world for U.S. funding and funding from other partners that are working more and more in this field, where one really good example is collaboration in East Africa surrounding biological security and lab capacity. So in Uganda, and I would only feel comfortable doing this because I've heard the minister speak about this eloquently as well. In Uganda, there was definitely a recognition that biosafety and biosecurity was really important, and the U.S. Department of Defense had funding for it, but also they needed workforce training, field epidemiology, and an emergency operations center. And so CDC and DOD came together with the government of Uganda and mapped out priorities and plans, which ultimately led to some of the work that is now going on in the context of the global health security agenda. So simply by having your health community and your security community comfortable with each other, it's important, and it paid huge dividends when we needed the Department of Defense to help with logistics in West Africa, because the CDC we were able to convene, and they know each other, and they know how to work together on these issues, and we knew what the sensitivities were going to be, and we were able to actually be much more effective in providing tools that we had sitting in one part of our government, but not in the other.
Thank you, Beth. I am going to go ahead then and close out this portion of our session. Thank you again for your time. Before we officially end this event, and part of the reason we're ending is because we want to preserve time for networking and food and beverage in the back. But before we do so, I would like to invite up Marion Wentworth, who is the President and CEO of Management Sciences for Health. Marion recently joined the organization from Merck. Come on, I'm just vamping while you walk in. But we're happy to have her as yet another new leader in this space. So thank you, Marion, for offering closing remarks.
And before I go further, Loyce, you've done a fabulous job of moderating. I watched her work just a little bit before this meeting, and I've always thought that she's quite articulate always. I've known her for like 3 weeks. But now I realize that some of that articulation is because she focuses on preparation, and I think that shows. So, distinguished colleagues, guests, and panelists, my name is Marion Wentworth. I am President and CEO of Management Sciences for Health, and on behalf of the organizers and sponsors of this event, it is indeed my pleasure to make a few closing remarks, and I'll do so quickly, and express my gratitude to everyone who made this program a reality. Many of you know, seems to be intermitting a little bit, is that? Anyway, okay. So many of you know MSH better than you know me. MSH has been a champion for health systems for over 45 years, and we're in over those 45 years, we've been in more than 150 countries. Currently, we're in about 40. We believe our commitment to helping countries improve all levels of their health system will create lasting health impact and pay dividends in times of crisis and in times of calm. By building robust health systems that are resilient and adaptive, with strong medical supply chains, effective governance practices, and diverse financial mechanisms, we can help countries prevent epidemics before they happen. We can make them more prepared for epidemics when they do. And in the meanwhile, we ensure that health services for every citizen, including the poor and most vulnerable, are maintained. We heard a number of those themes from our panelists this afternoon. We also heard a lot today about what is included in a broad health security agenda, and it is clear we must act in partnership and with a spirit of shared responsibility to achieve the goals behind global health security. This cannot be achieved by a single actor or a single sector. Success depends on collaboration between a broad range of private and public actors and among the health, security, environment, and agricultural sectors as well. And we heard a number of comments around that from our panel today. In that context, I think it's important to touch on the characteristics of what is a fragile health system. And our keynote speaker, Honorable Minister Jana Chang, reminded us that we're basically only as healthy globally as our weakest health system, that a weakness in one place affects all of us no matter where we are. And so looking at weak health systems, we observe several characteristics. First is the inability to provide health services to a large proportion of the population at the right time, of the right quality, and at the right cost. Second, when referral systems for the critically ill are ineffective or non-existent, they jeopardize the lives of individuals and they risk the lives of those around them. Similarly, a lack of infrastructure and human resources and skills adequate to detect and contain threats before they strike threatens to break systems and then create more harm. We heard an example of what happened with Ebola in the early days in 2014. Finally, non-operational health information systems make for poor disease surveillance, thereby preventing health systems from being able to detect emergencies early, but also making it very, very difficult for them to adapt and self-regulate if we are in the middle of a true health emergency of a regional or even global scale. Beyond lacking the ability to prevent disease outbreaks from becoming epidemics, inadequate health systems lead to increased poverty, fragile health systems, and they wreak havoc on local, national, and regional economies and infrastructure. That is, they create threats beyond health, and they create threats globally beyond health. So I was asked to summarize some of the things that were said today, and I could probably pick 3 words and just call it women, women, and women, but that would be cheating a little bit. So I will start with women, but also say a little bit about health systems and multi-sector. First of all, I think we've learned how valuable and important women are to global health security just by the panelists and keynote speaker that we heard today. What an amazing set of expertise. What an amazing gift to be able to hear from these women who not only care, but really know what they're talking about. Secondly, we also heard that 75% of healthcare giving is done by women. Women are at the front lines. Women are at the line behind the front lines. They're just not proportionally at the top of the global health infrastructure, but they are almost everywhere else. And actually they are at the top within country. I'm talking globally when I say they're not necessarily at the top. They also, as DIAH said, women get into you. And I think she was right. I think if we're going to have a more secure globe, we actually need a great deal of behavior change. And most of that is going to come from the kinds of characteristics and skills that women have. And finally, of course, women bear the disproportionate burden of collapsing healthcare systems and epidemics. And so that is one more reason to include women. From a health system perspective, you heard me talking about the importance of health system strengthening already. What we heard from the panel was that robust health systems are required, they're a basis for being prepared for global health emergencies. They require, however, strong human resource capacity building, good information systems, innovative technology support, strong labs, good supply chain. There was a long list that we heard from our panel today. But suffice it to say that strong healthcare systems are critical to global health security. And that's what we heard today. And then finally, I've said before, but I think the multi-sector theme was very strong this afternoon. From the private sector, we need resources, we need innovative technologies, but really in any emergency, it's all hands on deck. Everyone needs to participate. From the public sector, we need leadership, we need policies, we need strong governance, and we need public trust, because when those fall apart, a great deal more falls apart along with it. And from the international community, we need expertise, we need swing capacity, and we need the support to do capacity building in many of the countries around the world. So I just have to thank you all for joining us this afternoon, and thank you also for those of you who are joining online. It has been a very rich and thoughtful afternoon. I hope the discussion and the comments continue, and that you Twitter with the hashtag #GHSA. And a special thank you once again to the amazing panelists and the partners behind this event, Rabin Martin, Global Health Council, U.S. Pharmacopoeia, and No More Epidemics Campaign. Have a wonderful afternoon and rest of the assembly.